clean the ultrasound machine, but not how to use it. Though I've worked in obstetrics for 3 years. But I have some idea on infection prevention control, obviously, which sort of involves antibiotics as well. And so I earned this great talk. And I found out that the biggest challenge of all is to squeeze that topic into a 15 minutes talk. But I'll try anyway. So these are the challenges. When we deploy to a region that we haven't been to before, and when the data on endemic diseases is still scarce at the beginning, we don't really know what spectrum of diseases we will expect. And also we have very limited, if at all, access to microbiological analysis, let alone resistance patterns of the pathogens that cause infectious diseases there. At the same time, we have increasing antimicrobial resistance around the world. We have limited follow-up capacities. That means, I know that we are always advised to not give antibiotics out easily. For example, for a sore throat, we wouldn't give out antibiotics, but we'd rather expect the patients to return if they get worse and then follow up and maybe then decide on giving antibiotics. But if we all have them return after 3 days to check whether their condition has improved or not, our EMT will be overloaded by all these follow-up patients and we won't have time to treat those that are there as well to receive treatment, plus a lot of people to come to an EMT. It is quite a journey for them, and we can't just tell them, look, come back the other day if it's a several-hour journey and they queue up for quite a long time. So we tend to give out antibiotics a bit easier than we would do in Germany probably. We have to consider the side effects of antibiotics, and I'll talk about that in a minute. And also the application matters, and then the duration of therapy. We've just heard that the shorter the duration, the more we can rely on the effectivity of the antibiotics. And then also the dosage is relevant, and the induction of resistance or the selection of drug-resistant organisms. Some antibiotics induce resistance mechanisms of pathogens that usually are not resistant if you look at them. Only when you give antibiotics they become resistant. You know? And if you treat a patient with antibiotics and that patient carries within his gut, for example, resistant bacteria, then you will select these resistant bacteria by eliminating those that are not resistant, and then you have an increased transmission of resistant pathogens. And then, of course, like I said before, we are all urged to make rational use of antibiotics. So that leaves us with a few demands. The choice of antibiotics for EMTs must address the common diseases and cover all the common pathogens. They should consider global and local resistant patterns, and it's not easy to get data of local resistances. A lot of countries don't collect these data. They have no means of testing pathogens for their resistant patterns. They should be effective and safe, obviously. They should have high oral bioavailability. That means if you take them orally, we still want a systemic effect of antibiotics. Short duration of therapy, and I think it is good to have an ace up the sleeve for severe infections or unusual pathogens, and they do occur in disasters. I will show you that as well. So I think EMTs must be prepared for efficient empiric antibiotic treatment of infectious diseases. Now, of course, there are suggested selections of antibiotics. For example, these are the antibiotic contents of the Interagency Emergency Health Kit. And we all know that this kit is not designed for emergency situations, but rather for refugee populations. So if you look at the selection, we've got amoxicillin, we've got a cephalosporin, doxy, metronidazole, a few injectable drugs. And then if we look at the post-exposure prophylaxis kit, we have azithromycin and cefixime. It is a selection of antibiotics that we use quite often. Amoxicillin, I think, is amongst those that are mostly used in emergencies, at least in Type 1 teams, from my experience, and ceftriaxone is a very potent injectable drug. And then we have the WHO model lists of essential medicines for children and adults. And if you look at those groups here, then it covers almost all the antibiotics, and they are then divided into 3 groups. Group 1 being antibiotic that should be preferred as first-line antibiotics. They're usually effective and they don't cause too many side effects, especially with regards to resistance. Then we've got the group 3, a higher resistance potential and also a potential to select resistant pathogens. And then we've got the reserved groups, antibiotics that we use in very, very severe conditions and in a very narrow indication. So, I'm not going to go into the details of the treatment of the diseases, but I've at the beginning said that there's an unknown spectrum of diseases, which is not entirely true, because if you look at the literature, and I've done that, then these are the diseases that come up most of the time, and they seem to be the most common diseases in the aftermath of disasters. Diarrheal diseases, and I've picked shigellosis here because this is the one form of diarrhea, of bacterial diarrhea, that is mandatorily treated with antibiotics, whereas most of the other diarrheal diseases can be treated with oral rehydration solution unless they get really severe. Then we've got the acute respiratory infections, of course, and the most relevant here is pneumonia, but there's others as well. We've got the skin and soft tissue infections and wounds, especially if you think of earthquakes, for example. Urinary tract infections, and then we've got leptospirosis, diphtheria, meningitis, typhoid, maternal infections, and sexually transmitted diseases, and I've picked gonorrhea and syphilis here as examples. So, if you look at the guidelines, then again, guidelines and recommendations for treatments, for example, starting off with diarrheal diseases, you get a certain selection of antibiotics. Ciprofloxacin is recommended as a first line, and then you've got alternative choices. And what I will do now is, I'll pack all those that I think are relevant into a suitcase, and then later on we will unpack the suitcase together and maybe discuss on the selection of antibiotics. So from those that are mentioned here, I suggest to put into the suitcase azithromycin and ceftriaxone. Why am I not suggesting ciprofloxacin, even though it's suggested at first-line treatment? Well, recently there have been warnings by the Federal Drug Association of America, of the United States of America, and also within the European Union, and also in Germany in particular. And it is not recommended to use ciprofloxacin for all the indications that ciprofloxacin has been used before, because it has always been associated with rupture of tendons, for example, but there's been evidence recently that it is also associated with a higher risk of aorta dissection, and also, what's the English term for it? You know what I mean, problems with the aorta. Aneurysm, that's the one, yeah. Yeah. So the risk for getting that is between 1.5 and 2.5 higher than with other antibiotics. So in Germany, we are not supposed to use ciprofloxacin anymore. And if we are, on the other hand, forced to practice evidence-based medicine wherever we go, then we should consider that when we prescribe ciprofloxacin. And in my personal opinion, we should be very restrictive in the future on prescribing that drug. Moving on to acute respiratory infections, you can see that amoxicillin here is still recommended as first-line treatment by the WHO. But if you look at the pathogens that mostly cause pneumonia, which is strep pneumonia and Haemophilus influenzae, then we know that there's been increased resistance on the side of strep pneumonia, which might result in an ineffective treatment with amoxicillin, and then you have to have something to scale up your therapy, which could be, for example, amoxiclav, which is been combined with a beta-lactamase inhibitor, or turn to ceftriaxone, Ampigenta, and so on and so forth. And there's one drug specifically for Staph aureus. Staph aureus can cause nasty infections of the lungs, but also nasty bloodstream infections. And yeah, so if we put some of these things in the suitcase, and before I do that, let me talk about azithromycin, which you will find out is one of my favorite antibiotics now. You can see that even atypical pneumonia, of course, can be treated with azithromycin, and before we've heard the talk on x-rays and ultrasound, and if you have hints of an atypical pneumonia, you might as well just use azithromycin either as a monotherapy or as an additional therapy, and then your imaging would even help you to pick the right choice of antibiotics here. Whooping cough and diphtheria can also be treated with azithromycin. So let's pack some more in the suitcase, and you can see, maybe you can see, that these become fatter, and you will see exclamation marks. So whenever there's a new indication for an antibiotic which is already in the suitcase, I put an exclamation mark, and then you can see the relevance of the different antibiotics. Skin and soft tissue infections is a really tough one. I think a lot of people believe, and it is partly true, that penicillin can do a great job here, because a lot of these infections are caused by gram-positive pathogens like streptococci and staphylococci. But then, of course, we have an increase in methicillin-resistant staphylococci, and that is a problem because there's hardly any good oral treatment for MRSA infections. Maybe linezolid, which is available as an oral substance, can help here, although it's just bacteriostatic. And if you use one of those, doxy, Cotrim, or Clinda, there's also high resistances against these substances. And if you look at the gram-negative ones, then we have a problem. Enterobacteriaceae, these are bacteria that usually live in our guts. They can be comparatively easily treated. But if you look at Pseudomonas and Acinetobacter, which do definitely play a role in victims of earthquakes, and also we have found them in tsunami victims, then they are really hard to treat. And then you have to turn almost to reserve antibiotics like Piptas and Carbapenems. Now, let's look at some of the skin infections in particular. I think impetigo is quite a common one, and it doesn't necessarily require antibiotic treatment. You can treat it by just improving hygiene, basically, unless it's generalized or very close to the eye. For example, you might want to treat it with antibiotics. This one here is a tough one, necrotizing fasciitis. And we have seen that in victims, again, of tsunami, for example. It is a life-threatening disease, and it requires a quite potent selection of antibiotics. So taking all of that into consideration, the suitcase becomes packed little by little. And I said I was going to talk about these multi-drug resistant organisms. There's a few publications on victims of tsunami, 2004, 2005, they were published, and also earthquake survivors. Here's a publication from China, for example, and what they have found were a number of really highly resistant pathogens that caused relevant infections, for example, pneumonia and also wound infections, and these are not just little scratches, these are wound infections that require plastic surgery and vacuum coverage of the wound and so on and so forth. So if you want to treat them, then this would be a treatment of choice, and this is just reserve antibiotics. Carbapenems combined with vancomycin, and I'm only talking about bacteria now, but actually in that setting, fungus, different species of fungus were also relevant, and only with this combination plus surgical treatment, these patients could then be saved. So that, if we want to cover that, forces us to add some really potent antibiotics. Then we've got the urinary tract infections, and they are not so hard to treat actually, but the urologists that I know, and I don't want to offend any urologists, but their favorite substance is ciprofloxacin. And if we want to avoid that, then it becomes a little harder. Although cefixime, it's not available in Germany, so I don't really know it from experience, but the range of bacteria it covers seems to be quite appropriate for urinary tract infections, and can also treat gonorrheal infections, which makes it a drug that is actually recommended in a lot of guidelines. So we'll add some more. And then we've got the others that I mentioned, like leptospirosis, and you can see doxycycline plays a major role here, as does azithromycin. And for severe infections, you will quite often find that ceftriaxone actually works. Meningitis, a potent combination would be ampicillin with ceftriaxone, that is also within the German protocols and probably in the international protocols as well. But if you have an increased resistance patterns, for example, of strep pneumonia, then you'd have to add vancomycin to be sure. And typhoid, uncomplicated typhoid, can again be treated with azithromycin and also amoxicillin. For severe cases, again, ceftriaxone. So, and then the sexually transmitted diseases. I already told you that cefixime taken orally can treat gonorrheal infections, and if you combine it with azithromycin or doxycycline, you can actually treat pelvic inflammatory disease, which is a life-threatening, again, disease of the female internal genitalia. And then syphilis can be treated with penicillin or alternatively with doxy or ceftriaxone. So somehow the good old penicillin still makes sense to have. And you know, there's different versions of it. There's the benzathine, and there's the procaine, and there's just the penicillin G, and these are long-acting penicillins. This you have to give just once as a single shot application, whereas the Procaine lasts you for 24 hours. So we'll add some penicillins here into the suitcase. And then talking about severe infections, I think most of you probably know this very impressive study of Kumar from Canada, I believe, that shows you the survival fraction of sepsis patients in relation to effective antibiotic therapy. And the survival rate of sepsis patients is 80%. And with every hour that passes without effective antimicrobial treatment, the survival fraction decreases by 7 to 8%. And that is true for the first 6 or 7 hours, I believe. So you might actually end up as an EMT type 1, and the quick SOFA scale allows you to quickly get an idea of the severity of an infectious disease or a sepsis. You might actually end up having to treat or having to stabilize a person suffering from very severe infection before you can transfer him to a type 2 or type 3. So it might make sense to have something in mind or in your suitcase to treat severe sepsis. And my suggestion would be ceftriaxone and gentamicin, which are both long-acting antibiotics. You can use them single shot and you have enough time to transfer your patient. Although I'm not talking now about the intensive care medicine that is behind it all. That is just the antibiotic treatment, of course. And MRSA sepsis would require vancomycin again. And then you've got the sepsis after birth, and I think this drug is particularly interesting because if you have a strep A sepsis after birth, then the toxins are the ones that cause really the life-threatening condition, and with the clindamycin you can inhibit the production of toxins, so that is actually a life-saving drug in postnatal sepsis. So that's what we add finally. And then just a few slides on increasing antimicrobial resistance. I told you it's very difficult to get data on that from a lot of countries around the world, but there have been studies done on travelers that went to different parts of the world. And as you can see here, up to 88% of the travelers in this one study returned ESBL positive. And ESBL means extended spectrum beta-lactamase. And that means that certain antibiotics like penicillins and also cephalosporins don't work anymore. And these are now, this is a map that shows you carbapenem resistance around the world. There's different types of carbapenem resistance, and remember, carbapenems are reserve antibiotics, very, very broad spectrum, potent antibiotics. But these pathogens actually beam us back into the pre-antibiotic era. Some of them cannot be treated anymore. It's a 50-50 chance of survival. Yeah? And there's very funny ideas on how you can treat them, and they came up with funny words like suicidal drugs, for example, giving one drug to keep the pathogen busy and then coming in through the back door with another drug, or formulations that use colistin, for example, which is another one of these reserve drugs. So if we have severe infections with carbapenem-resistant pathogens, we're really in trouble, or the patient is, right? So, if we unpack the suitcase, you can see there's quite a long list on antibiotics, and it would be fantastic to have them all. But I realize that we try to be as narrow as possible with our choice. So let me narrow the choice a little bit. I think with the oral antibiotics, and I'm really interested in your opinion here, if we have a choice of these oral antibiotics, and you see the one with the little star here, I actually suggested by the WHO model list of medicines as type 1 or group 1 antibiotics, so antibiotics that usually are effective and not so dangerous with regards of antimicrobial resistance, and a few others that are still relevant in that context. And then with the injectable drugs, the gray ones here, I suggest, if at all, they should be reserved for type 2 and type 3 teams, and the type 1 team should have drugs for rather normal infectious conditions, and a few drugs like gentamicin and ceftriaxone, for example, to stabilize severe infections. And there's no limit to what type 2 and type 3 teams carry along if we have the idea to really be able to treat complicated infectious diseases. And that is all I wanted to say. Thank you very much.
Thank you, Daniel. Any questions for Daniel on antibiotic choices?
Do you have recommendations yet for the drug-resistant candidas that are now kind of spreading throughout?
Yeah, there is no recipe really on how to treat drug-resistant pathogens, and if you talk about these very drug-resistant carbapenem producing pathogens, then we really go into microbiological detail and we look at the minimum inhibitory concentrations, and if they are still comparatively low, although they have to be already interpreted as resistance, we can give the maximum dosage of carbapenems to hope to go over the minimum inhibitory concentration and combine it with colistin or tigecycline, for example, and that sometimes helps, but not in all cases.
And in terms of like this context, how feasible is that in an EMT type 2 even? I mean, it's not, right?
Yeah, well, like I said, if you want to cover these heavy conditions, and we've seen them in tsunami and earthquake victims, and if you're working in a surgical facility and you have wounds or fractures that are a couple of days old and you deal with these pathogens, yeah, you might want to have them, but of course I realize that we cannot prepare for every exotic condition that there is. Yeah? But I think with regards to resistance of rather common or normal pathogens, it's good to add amoxicillin with a beta-lactamase inhibitor, which is not in the interagency emergency health kit, but I think that is really a shortcoming of that kit. And like I said as well, ceftriaxone together with gentamicin can take you a long way. Yeah.
Do you have any idea of, in terms of the quantity, which drug is?
That is a very good question, and I haven't calculated any quantities. I think that would be another night shift or a couple of night shifts, and I didn't have the time to do all of that before this meeting. This is certainly something that that we could work on and maybe improve the selection of antibiotics in the future. I think, I don't know, what is your composition of the kits? We, as ASB, we use the interagency emergency health kit, but then we've got our individual additions to the kit, and we've added certain antibiotics to it because we just don't feel it's sufficient what there is, but that is the best approach to having medicine that is quickly available in disaster situations, and we don't have the trouble of rotating the medicine ourselves because they do it for us, the supplier does it for us. It's a difficult question.
I think that leads on to an interesting question.